And we'll get started. Okay, so I realize this is a broad group of folks that practice primarily in primary care, I believe. So I want to give a high level overview on really what's changed in prostate cancer over the last 4 or 5 years. I know sometimes you get into practice doing the day to day, and a lot can change in the background. So most of this stuff is now available in Idaho, and we provide comprehensive prostate cancer care from start to finish at IUI. So I just want to give a plug for our group. If you guys aren't familiar, we're an independent urology group that covers the St. Al's hospitals. And I want to spend the majority of the time talking about the newest treatment option that was offered as of February that can affect a lot of men in this area that may be patients of yours, family members, brothers, fathers, uncles, whatnot. So we'll go ahead and get started. There will be time to ask questions. Feel free to text it in the chat, or I think there'll be some time you can just turn on your mic and ask as well. So a brief overview.
Oh, Dr. Kuntz, I hate
Yep,
to interrupt,
that's
but
okay.
we cannot see your screen.
Try that. Is that better?
Yes.
Okay. I only made it through one slide, so here we go.
There you
So
go.
the
Great.
brief agenda, just want to give an update on the prostate cancer screening. What are current guidelines? It's certainly been a topic of controversy over the last decade. So if you haven't familiarized yourself with the updated screening guidelines, I want to touch on that briefly. There's a few newer pre-biopsy diagnostics with either imaging and different lab tests that I want to make everyone aware of. And then certainly different newer staging modalities that have been implemented really over the last 5 years have become pretty standard. And then I'll spend the remaining time talking about HIFU, high intensity focused ultrasound, what it is, and how it works. So any cancer talk, a prerequisite, you have to have the American Cancer statistics. This breaks down how prostate cancer affects men, specifically in the US. This is 5-year data. I typically would summarize this as roughly 300,000 men are diagnosed per year with cancer, and about 30,000 of those are going to be lethal forms. So a large percentage of men are going to be diagnosed with a cancer that are not lethal. And so the transition, and one of the reasons this talk is titled A Paradigm Shift, is many of these tumors ought to be treated as a chronic disease. And so offering really aggressive treatment options for a problem that may not be lethal is kind of the issue that we've run into over the last several decades. So just as a review, some of you may have been in practice long enough where you experienced the 2012 reversal of the U.S. Preventive Services Task Force group grade D recommendation. So they recommended against prostate cancer screening, and then subsequently reversed that in 2018. And probably have seen some of the fallout from that in terms of delayed screening, delayed diagnosis, and men preventing with more advanced disease. And certainly with the 2020 lack of follow-up or just medical care in general, we certainly have seen an uptick in folks presenting with later stage disease from that. So anecdotally, clearly on an individual basis, screening is quite helpful. There is certainly some controversy in the large population data set, but without going into too much detail, I pulled the recent AUA, which is the American Urologic Association guidelines. This might be helpful to have this one screen printed out just to review from time to time. I'm going to focus on the left side of the screen, which are the general guidelines from a primary care standpoint, and then when folks should be referred for specialist care. So every guideline will include a shared decision-making paradigm. So, some sort of discussion in a patient clinician environment where you build some consensus, you discuss the risk and benefits of screening, and then after some discussion, you decide you want to proceed with that. Now, that said, most Medicare will cover one PSA screening per year, and typically what I see from folks getting referred is most men, starting at age 50 or so, are getting at least one PSA per year. How much discussion goes on, we kind of leave up to you guys. Certainly, some questions we get asked often is, when do we start this? And again, this instead of being a specific age or number, kind of includes more of a range and including risk factors. And so for most average risk, so really no family history, non-African American, starting somewhere between 45 and 15, getting one baseline PSA is quite reasonable. And then certainly with higher risk factors, even as early as 40, may benefit from one PSA. And then certainly what to do after that would depend on what that level is. So at age 40 or 45, getting one PSA, if it's less than one, you could certainly postpone that for several years. The interval, rather than being annual, they've actually broadened that to every 2 to 4 years. But they leave some flexibility so you can make some individual assessments on risk, and you can modify that as you see fit. And then certainly at some point, they no longer say, hey, you should stop screening at this age. It really leaves that up for some interpretation. Now, I think what's important to note, historically, anyone that had a PSA over 4 was getting a biopsy, and anyone that had a biopsy and had any degree of cancer was getting either radical prostatectomy or radiation. So that has been one major paradigm shift even over the last 10 years. And certainly prostate MRI has become quite ubiquitous. It's almost universally covered by all payers. And so my personal practice, I have a high reliance on prostate MRI. This is not a garden variety type of MRI. It does require a 3 Tesla magnet, certain protocol, and then radiologists that are familiar in reading it. But it has quite good diagnostic accuracy if it's both positive and negative. And similar to breast cancer screening, it'll give a score, what's called a PIRADS grading score, where a PIRAD 3, 4, or 5 will have a sensitivity of 93%, and anything 2 or less has a negative predictive value of about 96%. So it's quite good at excluding clinically significant cancer in men that may have a PSA of 4, 5, 6, somewhere in that range. And it can show other information about the prostate size and shape. It shows quite good pictures of BPH, for example, and it allows us to be more selective on men that end up having a biopsy, number one. And number two, it helps target biopsies thereafter. So I've selected a few. These are from my own patients, so I didn't select these, low-hanging fruit pictures, but this is a really common finding. So on the left, you can see 1.4 centimeter lesion in the posterior aspect of the right hemisphere. And so, typically that would fall under a systemic biopsy, but other lesions that may not. It allows us to put several biopsies through an index lesion and thus gaining a higher diagnostic yield from each biopsy. So prior to imaging even, a lot of research dollars recently has gone into biomarkers. So whether it be urine, semen, blood tests, ways to further risk stratify men based on, that have a higher diagnostic yield than PSA alone. And this has been going on for decades trying to do that. The one we have adopted here is something called ISO-PSA or isometric PSA. And really in every scenario, the positive predictive value for any of these really doesn't get much better than 50%. I think the biggest utility for these tests is the negative predictive value. So men that come in with a PSA that is either increasing or high, running a test like this, if it comes back to be negative, is quite useful in excluding prostate cancer and can avoid unnecessary biopsies in many cases. So typically we offer this, and if this is high, then move forward with imaging. And then if imaging is consistent with a likely lesion, then we proceed with biopsy. So prostate biopsy remains the standard of care in terms of diagnosing prostate cancer. There's really no other way to do that. What has changed relatively recently is the approach for that. So historically, and still in many places across the country, a transrectal biopsy where the needles are actually passing through the rectal wall into the prostate tissue certainly carries some infection risk, which may seem intuitive, um, and requires antibiotics and still has a sepsis rate of maybe 1 to 3%, somewhere in that range. So using what's called a perineal approach, the needle is actually traversing through the perineal skin into the biopsy to obtain samples. Still requires a transrectal probe for guidance. It's done under local anesthetic, but is quite well tolerated. It takes about 10-15 minutes, but has zero infection risk even without antibiotics. So these are routinely done here at IUI, and we've been able to avoid many infectious complications as a result. Okay, moving forward with some newer staging modalities. So historically, new cancer diagnosis would undergo a CT and bone scan, which had very poor sensitivity and specificity for prostate cancer unless your PSA was very high or your disease was quite advanced. So PSMA PET CT, you're probably familiar with PET in general, but PSMA stands for prostate-specific membrane antigen. It's a specific protein that's found in high levels of prostate cancer, or is expressed in high levels. So it's a quite effective targeted approach for assessing the extent of disease. So primarily, this is being offered for high-risk candidates who are likely to have or have some risk of occult metastatic disease. And prior to offering a focal or local therapy, you want to exclude that. The other useful indication for this is in the salvage or recurrent setting. So they've had treatment with either prostatectomy or radiation or some other form with a biochemical recurrence. You want to know where is that tumor located? Is it in lymph nodes? Is it in bones? Is it other places? So that's the primary utilization currently. And it's quite good for this. So quite sensitive, quite specific. There are certain forms of prostate cancer that do not show up on this, so it doesn't cover every possible scenario. But on the lower left, you can see a corresponding lesion on PET scan, which is quite bright and correlates with the MRI lesion right next to it. So these can be used in conjunction with MRI, but primarily are used to stage folks that may have occult metastatic disease and need more aggressive management. Okay, so I'll spend the remaining minutes discussing newer treatment options, and certainly anyone listening probably has had exposure with patients who have been diagnosed with prostate cancer. And then there's a plethora of options that are thrown at them, including watchful waiting or active surveillance, which is reasonable for some men, but then really considering the long-term side effects of various treatment options, namely with regard to sexual and urinary function and maintaining some of that. So certainly more recently, my experience has been that men are putting a high premium on quality of life and avoiding some of the long-term side effects associated with some conventional treatment options. So we've seen similar shifts in other types of oncologic malignancies, specifically with breast cancer. This has been over decades now, where you're not getting a radical mastectomy the vast majority of the time for a small localized breast lesion. Lumpectomy, has demonstrated quite good oncologic principles, and so the same treatment strategy is being shifted towards both, kidney masses and then certainly for prostate. Prostate is a little bit unique in that the tumors can be a little more infiltrative. They don't have distinct borders. And so for a long time, a lot of the data for focal treatments has been all over the place, and it hasn't been quite well adopted universally. However, there's still a good, strong reason to desire focal treatment, namely in minimizing the side effects from a more aggressive radical treatment. even with robotic prostatectomy, which is a great surgery. It's a surgery I do. Still comes with these risks of urinary and sexual dysfunction. So that's kind of the evolution in other oncologic realms that is starting to gain steam with prostate cancer. So HIFU stands for high intensity focused ultrasound. This is essentially a focal treatment using thermal energy, which is created by sound waves. So it's totally non-invasive. There's no cutting, no incisions. It's using ultrasound energy, so you can completely avoid radiation and that type of tissue damage that results from radiation. And because of that, if folks aren't universally cured and need a salvage treatment, number one, surgery and radiation are still options, is in addition to salvage HIFU. So you can undergo more than one treatment for this. The main benefit is to ablate or destroy part of the prostate and avoid the structures that maintain good erection, maintain urinary continence and function, so folks aren't having to wear diapers or pads and that type of thing. So there are different platforms for delivering this energy source. The one that we have launched here is a brand called Focal One, and it uses a transrectal approach. So this is the actual platform. There's a probe that has the real-time ultrasound and the energy source built in, and then the monitors over there on the right. So this is where you sit during treatment, and the treatment is calculated on the back table using a real-time ultrasound imaging, and then the robotic arm that actually is responsible for delivering the energy to the fields that you set. So I have a short video here I'm going to play that kind of gives you a better idea of how it actually works. Start right here.
Designed for urologists to perform focal ablation of prostate tissue. It combines all the latest innovations in imaging, robotics, and HIFU technologies to offer a precise and user-friendly tool in the hands of the urologist.
Oh boy.
The endorectal probe and robotic positioning system.
Hold on. Can you see both these screens?
Yes, I can see both.
Don't want two playing at once. There we go.
Designed for urologists to perform focal ablation of prostate tissue. It combines all the latest innovations in imaging, robotics, and HIFU technologies to offer a precise and user-friendly tool in the hands of the urologist. The endorectal probe and robotic positioning system are unique to Focal One. The probe features a dedicated ultrasound imaging transducer, allowing real-time imaging at any point during the procedure. The HIFU transducer around it incorporates proprietary dynamic focusing technology for pinpoint precision of ultrasound energy. All movements are robotically controlled with 5 degrees of freedom, and the system auto-adjusts in real time for the position of the rectum. The HIFU procedure is performed in an outpatient setting. The patient is placed on a standard OR table in a lateral decubitus position under general or spinal anesthesia. First, the probe is manually inserted into the rectum by the physician. The system will then automatically acquire a 3D ultrasound volume of the prostate. This high-resolution image allows visualization of critical structures. The operator can seamlessly import diagnostic images, such as MRI and 3D biopsies from various platforms. These volumes are then registered with the real-time ultrasound using a proprietary elastic fusion algorithm called HiFusion. The yellow target area defined on the MRI is automatically overlaid at the right position on the real-time ultrasound image and will be used as a visual guide to plan the treatment. The urologist then precisely defines the upper and lower limits of the treatment zone. The computerized system creates virtual slices every 1.7 millimeters to cover the whole ablation area. For each individual slice, the operator shapes the contour of the target to provide a safety margin around the lesion while avoiding critical structures. The Focal One robotic system will execute the plan, controlling and readjusting automatically before each individual pulse of HIFU energy. During the process, the urologist maintains control and monitors the ablation through real-time visualization. They can pause and readjust the plan at any time. As shown here, the area ablated can be clearly visible on imaging, highlighting that the critical structures of the prostate are spared, minimizing the risk of side effects such as incontinence and erectile dysfunction. Once the procedure is complete, the patient is sent home the same day with a catheter and can rapidly resume normal activities.
This is the next iteration of the way we're going to treat prostate cancer. Like robotic surgery was 20 years ago. If you didn't sign on to robotic surgery 20 years ago, you were out of the prostate business. You don't have some form of focal therapy 20 years.
Okay. So, okay. So I'm hoping that gives you just some sort of idea about what to expect. You may start seeing some folks that are either interested in this or at some point have had it done, and so some understanding of what it consists of. So we launched this program in February. We'll have about 30 cases this next month or two, and so we've had a very high demand. It's been quite successful in my opinion so far. In terms of what patients are coming back of complaining, it's quite minimally invasive. They do have to wear a catheter for about a week. But in terms of side effects and recovery, it's been quite good. Now, one thing to point out, this is not meant to replace, or actually, I'm going to get into that in the next slide. So there has been certainly more and more evidence that have come out, at least in the last year, head-to-head comparisons with prostatectomy. And the evidence in terms of oncologic outcomes have been quite favorable, assuming appropriately selected patients. So this is not meant for high risk folks that need more aggressive treatment. It's really for the intermediate risk zones that could be monitored for several years, could have an aggressive treatment, but also are good candidates for a focal therapy that have a high chance of cure with minimal side effects. So if you see these different side effect comparisons between active surveillance, radiation, and prostatectomy, we don't have nearly as long-term follow-up on the focal treatments compared to surgery and radiation, but what you can easily see is that a significant decrease in incontinence, erectile dysfunction, strictures, and all of those things that men care about. So again, not meant to treat everyone. This shows the range in terms of risk of prostate cancer, ranging from low to metastatic. Certainly high-risk individuals that have a lethal form of cancer are going to need a more aggressive treatment. So that's where surgery and radiation are going to still play a strong role. Some men, even with intermediate risk, still are going to require that. But focal really falls into the low-risk category where men may have too much anxiety about an active surveillance protocol, or are tired of getting biopsies every 2 to 3 years. This is certainly where something like HIFU can play a strong role in there. But clearly there's still a role for surgery and radiation, and then certainly in the salvage setting, specifically after radiation, more aggressive surgical options are really fraught with high risk of side effects and complications. So you can, in a salvage setting after radiation, use HIFU. That's one of the other main indications. So in terms of patient selection, so outcomes are going to be consistent with patient selection. So higher grade tumors are more likely to be resistant to this type of energy, similar to radiation. So Gleason, using the Gleason scoring system, Gleason 6 and then Gleason 7s are going to be the most favorable candidate. You want, in general, smaller prostates versus bigger prostates. There is a maximum length of treatment, so has about a 4 centimeter reach in terms of how far energy can be delivered away from the probe head. So that gets factored in. Location of the tumors, really, these posterior peripheral lesions are going to be ideal. And there's certainly some contraindications that are listed. namely really dense calcifications can, because we're using sound wave energy, can be disruptive to heating up a specific area. So without going into a ton of detail regarding outcomes, this is the most recent study that was published last summer and we presented at the AUA meeting last year. So this is a head-to-head comparison. It's called the HIFI study, comparing HIFU to radical prostatectomy. It was prospective but not randomized, and had about 2,000 or so men in each treatment arm. It compared prostatectomy to HIFU with about 3-year follow-up. So this was designed as a non-inferiority study. They looked at urinary incontinence, erectile dysfunction, all those long-term side effects. And essentially, you can see HIFU actually compared was statistically better, at least at 3-year follow-up, with lower recurrence rates from an oncologic standpoint, and clearly demonstrated less side effects with regard to sexual and urinary function as well. There was an additional study out of Norway, Oslo, reported similar findings when compared head-to-head with prostatectomy. So I think the platform, so the energy, the technology, energy delivery system, and the platform is now to the point where the inter-user variability comparing one surgeon to the next is minimal. So using the robotic arm, you don't have a significant learning curve. And after only a few cases and someone that's experienced with treating cancer and looking at ultrasound images, you can have really good outcomes. So to summarize, the main benefits of a focal therapy, clearly, the recovery time, there's no incision, there's no risk of blood loss. You completely avoid radiation, which can be time intensive and have scar tissue that develops in the pelvis. And then it fits a specific subset of men who don't have a lethal form of disease, but may live long enough to develop symptoms of the disease. So we can treat that early with minimal downstream side effects and have still good cancer control outcomes. At least in the intermediate range, it has demonstrated to be non-inferior to the conventional options, namely prostatectomy, and then the newer options that combine the robotic instrumentation delivery platform gets people in and out of the hospital easy with quite minimal recovery time. So that's my pitch. And some of you, like I said, may have patients or family members that are hesitant to undergo screening because then they had a friend or family member who was in diapers the rest of their life. And there's just a lot more options that we have available nowadays for men with these localized disease that they don't have to necessarily sacrifice the quality of life issues. So that's all I have in terms of presentation material. I'm happy to take any questions anyone may have.
Can you see the chat?
Are
you able to view it? Or I can ask.
Yeah.
Dr. Norp asked, when do you recommend a